Well, I've got 10:01, so I think we can get started. Good morning, everyone. Welcome to the second day of the February 2021 committee meeting. We will begin by taking roll. Start with committee members. Kamala Mistry.
Here.
May Baker.
Here.
Jeff Brosco.
Here.
Kyle Brothers.
Here.
Jane DeLuca.
Here.
Carla Cuthbert.
Here.
Kelly Kelm.
Here.
Michael Warren.
Here.
Sean McCandless. Melissa Parisi.
She's on the phone in the audience. We're getting her promoted right now.
Okay, thank you. I'm here. Anna Marie Saranen.
Here.
Scott Schoen.
Here.
And our organizational representatives, Robert Ostrander.
Here.
Deborah Friedenberg.
Here.
Maximilian Mjunke. Stephen Ralston. Jed Miller.
Here.
Susan Tanksley.
Here.
Chris Kuss.
Here. Here.
Shakira Henderson.
Good morning here.
Jennifer Kwan.
Here.
Jacob Hoag.
Here.
Natasha Bonham.
Here.
Sean Dolan.
Here.
Kate Walsh-Vockley.
Here.
Georgianne Arnold.
Here.
And anyone who wasn't able to get through who's joined in the interim. Okay, thank you. So we'll begin with updates from the work group meetings that were held yesterday afternoon. The work groups convened to consider processes for the review of conditions on the RUSP and potential updates to the committee's condition nomination form. After their presentations, the committee will have the opportunity to engage in discussion. Our final session of the meeting will be a panel on innovations in long-term follow-up. I'll now turn it over to Mia Morrison, designated federal official, to provide guidance for participating on the webinar.
Thanks, Dr. Powell. Members of the public, audio will come through your computer speakers, so please make sure to have your computer speakers turned on. If you can't access the audio through your computer, you may dial into the meeting using the telephone number that was in the email with your Zoom link. This meeting does not have an all attendee chat feature, but there was a period for public comment yesterday. Committee members and organizational representatives audio will also come from your computer speakers, and you'll be able to speak using your computer microphone. If you can't access the audio or microphone through your computer, you may also dial into the meeting using the telephone number that was in the email with your Zoom link. Please speak clearly and remember to state your first and last name to ensure proper recording for the committee transcript and minutes. The chair will call on committee members first and then organizational representatives. In order to better facilitate the discussion, please use the raise hand feature, which should be located on the bottom of your screen. Depending on your operating device or system, this may appear in a different location. I'll now turn it over back to Dr. Powell.
Thank you, Mia. First, we have the Education and Training Work Group chaired by Dr. Jane DeLuca. Dr. DeLuca.
Good morning, everyone. Mia, do you have slides or should I put them up on my end?
They'll be putting them up momentarily.
Okay. Good morning. First, I wanted to acknowledge all of our members in our Education and Training Work Group. And if I've left anybody off the slide, I apologize. Next slide. So in terms of our two questions, We concentrated mostly on the first question: what range of issues related to education should the advisory committee consider when a condition is added to the RUSP? Next slide. And these were the types of topics that we came up with in our discussions. And it was really a very, very fruitful discussion. So we started off thinking about what are we trying to achieve or improve in terms of screening through our informational efforts. What do we mean when we say education? Is this awareness, training? Should it be directed towards parents, providers, or other stakeholders? Are there increased risks in screening for certain populations? What does the diagnostic and treatment process look like? Do we have a roadmap? And how do parents and providers navigate this? What are some of the aspects of providing support to parents upon notification of an abnormal newborn screen? And what types of tools and in what languages are needed so we can appropriately educate different stakeholders? So there are many different learners involved throughout the newborn screening system, but we do not want to reinvent the wheel. We discussed an existing tool, what stakeholders need to know. And this was a grid that was constructed, and it's actually posted on the advisory committee website on 2018. So considerable work went into this tool, and it brings together 31 different stakeholders, and that's matched with what they need to know in 28 categories of knowledge, which is specified for each stakeholder. And at the end of the slideshow, I'll show you an example of that, but it's really quite a useful tool, and it was good that we revisited this and brought this back into the forefront. So along the lines of education, there are excellent sources of educational materials that already exist. There are resources in Baby's First Test. There are broader organizations that are putting information together for screening conditions and bringing that into the public sphere. But to answer this question, we need a better foundation to begin with, not just focus on disease-specific information. So we discussed considering early education in the nomination process. This can be a bi-directional dialogue to increase awareness across different stakeholders. Early dialogue between stakeholders from the nomination point to implementation can really aid in getting the word out in terms of what people can expect. Getting a perspective on education that's needed early in the nomination phase rather than waiting until a disorder is implemented could really be useful. What role can the advisory committee play within its framework and limited resources? What is the advisory committee set up to do? One suggestion was that in lieu of reading the entire report when a condition is nominated or added after the secretary approves, there could be a one-page description of why a disorder was added and what happens next. The goal of education by the advisory committee could be to tell what is being done as a particular condition is added to it at a particular time, breaking down the information about the nomination. This might help improve public understanding, as parents and providers may not be aware of the process. People do not oftentimes know when a particular disorder is chosen. Explaining this may give perspective to those who are asking the questions as well as those who are posing the questions. An example of this in the group was that there's a website in the UK where all conditions are considered, that were ever considered for newborn screening are listed, and you can click on the condition that did not go forward and learn why. It seems to aid in helping people understand the general process. So can we consider creating something new that will capture important facets of the questions that are being asked? For example, how long would it take in a particular state for a screen for a new disorder to be implemented? Why was a disorder decided upon? What are other states doing? And why is it taking so long, for example, to have a disorder come to a particular state? Education during decisions about a condition for the RUSP. When is education considered during the decision-making process for a condition nominated for the RUSP? Or does this figure at all in the process? The group thought that this was not considered very much as far as we know, but it's an excellent point, and it may be captured in the APHL survey of the states or not. But this is an excellent suggestion that came forward. The group discussed benefits and harm. There's no agreement among stakeholders for what constitutes benefits and harms in different newborn screening conditions. So there's diverse opinions. One group may feel preventing mortality may be sufficient, but for another, this is not sufficient benefit to consider screening. Advocates have differing views, as do states, and even within the advisory committee itself, there are different thresholds for benefit and screening. How can we define physical versus psychosocial harms and benefits and the magnitude of each? Potential harms in newborn screening have been present since the very beginning of the screening system. How do we educate about potential harms? Is there a way to communicate this within the nomination process? Should it be requested of a nominating group, for example, that they consider benefits and also harms of screening from their perspectives? But this is a very difficult topic, and defining harms can be challenging for all of us, but it certainly is warranted inspection. Different varieties of state screening systems. There's a wide variety of state screening systems, and some take the federal recommendations as is. Some have their own RUSP process or decision-making mechanisms. There's a federal layer, and then there's a state layer of policy. There are issues considered important to states, but maybe less important to the advisory committee. We debated that it could be important to educate the public of these existing differences between states, that not all states are exactly the same in their differences in approach to screening and available resources. Of note, there are limited resources in states for screening as well, and costs are not discussed as a rule as an education point. This is especially important now since COVID has seized health departments and new disorders may not be added. Start with those who are least informed. If we are thinking of a one-page sheet for education about advisory committee activities, such concerns regarding benefits and harms or differences in state screening systems and panels exist, but who should we target? Do we want to make a professional sheet and a non-professional single sheet? It was suggested that at least information that the least informed of stakeholders might benefit the most. Educating newborn screening staff was suggested because not everyone gets the advisory committee meetings, or perhaps policymakers and healthcare providers may be the least informed. Perhaps legislators, because they are often involved in these decisions at a state level. State advisory committees, because they make these decisions, may not know all aspects of newborn screening. What types of information, so for our second question, what types of information resources would be most helpful when a condition is added to the RUSP? So there were a few thoughts on this. An education issue might be useful as conditions are added to the RUSP. Information could be made available on a variety of targeted conditions, such as the identification of late onset disorders or secondary conditions. What about case definition? What are we screening for versus what we might pick up? And conversely, what might we miss? Education can help mitigate some of the harm and support families through the process. And education may closely be tied to the nomination and evaluation process, and we can examine barriers to that process. The group discussed the communication guide during the review process. This, again, was a tool that was created and posted to the website in 2018. So this is for disorders to help think about how initial notifications of newborn screening can occur and guide the discussion about the conditions. So to summarize, the committee focused on education about the advisory committee and the nomination review processes, acknowledging differences in the many stakeholders and state systems, avoiding reinventing the wheel and revisiting stakeholders' grid and communication guide resources, the topics of harm and benefits, costs, early education in the nominating process, informing the public providers about the nomination process, and informing the least informed among them, and the possibility of creating one-page informational guides or answers to address the questions posed to the Education and Training Committee. And can you just turn to the next slide or the last slide? And this is just an example of the tools that I had talked about, the communication guide and the grid.
Thank you, Dr. DeLuca. As you said, there was a lot of discussion yesterday during that work group meeting, and certainly building upon the previous work of the Education and Training work group will be very helpful as we move forward with this. So as a reminder, we're going to hold questions and comments until all three work groups have presented. Next, we have the follow-up and treatment work group chaired by Dr. Jeffrey Brosco and co-chaired by Dr. Christopher Kuss. Today, Dr. Brosco will present the work group update. Jeff, you're muted.
Oh, my apologies. And what I said was brilliant. I'm sorry you guys missed it.
We missed it.
It's always interesting to see how much the content of what the different work groups come up with, even though we have different charges, is so similar. And I think you'll hear that as we go through this. There's no way we can cover the richness of the discussion in our 10 minutes, but I'm lucky in that our panel discussion starting at 11:10 is on these same topics. So I'm going to spend most of my time reviewing what the follow-up and treatment work group has been doing over the years, because as Jane pointed out, we've done so much of this work before. Next slide, please. So it's interesting, even though we have a new group of folks, there's some turnover, that a lot of the discussion we did yesterday led to many of the same places where we were in 2018 and 2019. And I want to particularly acknowledge Chris Cuss for helping organize our very unruly group at times. It was a wonderful discussion. Next slide, please. So just to remind everyone what our charge is, we are responsible for working on barriers, recommendations, and who's responsible for screening, implementation, short and long-term follow-up, and that includes treatment that are relevant to newborn screening results. Next slide, please. And just a couple words on what we mean by follow-up and treatment. These are very strange things, but we have discussion where we've been using the word follow-up. And for clinicians, this implies treatment. I'm a pediatrician. If I'm following up a patient, that means I'm going to treat that patient every time I see them. But for many others, for researchers, they may say, well, you know, in 5-year follow-up, the survival rate was blank. And so one of the things we want to make sure is that when we say follow-up, we actually imply treatment, and it's part of our work group name. The other thing is the word long-term. When we looked at this really closely a couple of years ago, we realized this means very different things to different people. For some people, 5 years, age 5 is long-term follow-up. And most of us would agree, well, that doesn't take into account things like learning disabilities and stuff that happens after that. So we've been trying to use the word longitudinal, which includes lifespan. So instead of saying long-term, I'm going to try to remember to say longitudinal. Next slide, please. And what are some examples of longitudinal follow-up? So there are sort of 3 main categories. I'll talk about this more later, but they're what the researchers are primarily interested in. Did early treatment make a difference? Then there's the quality improvement assurance return on investment, which we talked about a lot yesterday. It tends to be the purview of particularly larger organizations. And then perhaps most importantly for families and each of us as clinicians and at the bedside is, how is that particular child doing? So we want to know over time. And there's obviously overlap among the 3. Next slide, please. So what have we done to try to get here? Let's skip this slide for now because we'll talk about it more later. Starting in 2006 was sort of the first major publication where Alex Kemper and the work group laid out some of the central components of what follow-up should look like over the years, and that included care coordination, evidence-based treatment, and quality improvement. And they said there are certain features that were really important. And you see, at least over a decade ago, they laid out most of what we need to know. Next slide, please. And then Cynthia Hinton and the work group at that time followed up, emphasized those central components, and then talked about those different perspectives. And we'll deal with this a little bit this afternoon, that they're both state and nation, primary care, specialty providers, and families have different views on this, and they kind of went through and laid that out. Next slide, please. And then perhaps most useful is the work of Cynthia Hinton and that work group, which created this framework in 2016. So you go to the next slide, please. Just want to stay on this for a minute, because in some ways, as Jane was saying, things have been laid out in previous work groups. Well, things have been laid out pretty nicely for us. So you can see on the left side, there are these outcomes, and they are the major outcomes we would all think would be important for any condition. And then they talk about the primary drivers. What are the ways we get to those outcomes? And then even put in place what could be some of the, conceptually at least, what should we measure to know whether we've reached those outcomes? Next slide, please. So a couple of years ago, our work group tried to work on those measures in particular, and Alan Zuckerman and others really helped lead us through this to say, well, these quality measures are a crucial part of our healthcare system nowadays. They're the way we know we're getting where we need to get. There are lots of different kinds of quality measures. We talked a little bit about how this would all fit together. And I'll spend more time on this afternoon when we talk about long-term follow-up in that context. So in this as well, we'll talk about this afternoon, but this idea of a federated system, that the United States healthcare system is highly fragmented. This is just the nature of the beast. There's no way around it. So if we wanted to create a way of keeping track of all these different components, we need to kind of federate different pieces of it. Next slide, please. So here are the questions that we were discussing yesterday, which fit in with the work we've been doing really over the last decade. So the first one, what kind of longitudinal follow-up information should we consider when a condition is added to the RUSP? Next slide, please. I almost didn't have to change at all our slide from a couple of years ago. And we discussed this yesterday morning as well. So we would argue that when a condition is considered, we should be thinking about longitudinal follow-up right from the very beginning. And I love the way that Sean again has talked about this relationship, that the nominating group sort of proposes some ideas, and that begins a relationship, not just with HRSA and MCHB, but with state newborn screening labs and so on. It creates an opportunity for us to learn from each other. And the key components that we all agreed on yesterday, and this was the bulk of our time, was that we want to make sure that infants have some access to treatment. I'll come back to this later this afternoon, because there are some really tricky issues about what we mean by equity and how far we can go. But there should be at least some ideas about, if we screen for a condition, will children who are identified have a chance of actually getting treatment? Because if not, that's a real problem. A second key idea is, what is the best outcome measure? How do we know we've been successful in newborn screening? What really matters? And we think the nominating group is in a good position to participate in that discussion and should say, these are the kinds of things that are really important to us as researchers, as clinicians, as family members, as youth and adults who have the condition. And they should have a say in what is the important outcome. And then lastly, that there should be at least a plan, some idea, a prospect of how we might collect this data over time. Is it a patient registry? Is it going to be through the some of the approaches we're going to hear later this afternoon from New Steps or others? Now, it's important to say that we think that this process should not be part of the scoring. You know, we shouldn't say, yes, everyone has access, so therefore it should be on the RUSP or not, but that we should at least begin thinking about longitudinal follow-up from the beginning. This has become, some groups have a lot more access to resources than others, and we don't want to create a bar that people can't reach just because of resources. Next slide, please. The second question was about systematic review of conditions on the RUSP and when that should be done and what information would be important. And here are some of the main ideas that came out of our discussion yesterday. One is the idea that during evidence review, Alex and his team come up with these models that say, here, what we think is going to happen, here's the ratio of benefits to harms. And maybe we can use that as an organizing system for thinking about conditions 5, 10, 15, 20 years later. And there's also the value that we get some lessons learned. What did we learn from our modeling and how it actually played out? The equity, population health issues came up a fair amount yesterday in our work group. Did everyone benefit from newborn screening state programs equally, or were there disparities that we need to address? Following up on May Baker's comments yesterday, a number of folks talked about, well, what actually is the condition? What's that range of diseases? Once we start doing newborn screening, you have secondary targets, late onset, what's the real prevalence? And that's information that's going to be really important for informing decisions in the future. And I think you heard Bob Ostrander yesterday talk about harms as a way to prioritize. What are the red flags? And maybe one way to think about when we should review a condition is if the ratio of benefit to harms changes, maybe it's time to do a closer review. And then Jed Miller had a really nice idea about talking about barriers and systematically collecting information in these common categories so states could learn from each other over time. And then lastly about this, what conditions to review and when should it be 3, 5, 10 years? One idea is that it could be sort of a two-step process. And maybe there is a routine where, 10 conditions are reviewed every year in a very brief way. So what does the published data say? Quick survey, and identifying ones where the ratio of benefit to harm has changed significantly and therefore requires a much more close look. Next slide, please. The third question for us was the cost of treatment. And everyone agreed that this should be something we need to look more closely at, but there was a lot of feeling that this probably should not influence whether something's put on the RUSP or not. And Anne-Marie Sorensen made a really critical point, which we all rapidly agreed with, which is it's probably not right to think about this as cost of treatment. If you say something costs, $700,000 a year to implement, that's out of context. And really what we should probably be thinking about is access. And she suggested the WHO definition, which here, we'll talk about this a little bit later this afternoon when we talk more about equity. So we think that cost is worth thinking about, but we really just began our conversation yesterday. Next slide, please. So this is just a little hint of what we're going to talk about later in terms of cost and access and equity. And that is, if you think about newborn screening programs at the state level, we do a really good job probably regarding diagnosis in terms of equity, but probably not so much at treatment. And so that's really one of the bigger issues we'll talk about as well later this afternoon. We only briefly touched on it yesterday, but these are things we think we can be focusing on more in the future. And I think that's my last slide, and I will turn it over to Kelly.
Thank you, Dr. Brosco. We look forward to your presentation this afternoon, you and the others. Certainly this is such an important area, as you know, one that I'm very interested in, and think and hope we can move forward. So many other countries do a much better job than we do in terms of the longitudinal follow-up tracking. So thank you. And now I will turn it over to Dr. Kelly Kelm, who is chair of the Laboratory Standards and Procedures Work Group, and will give us their update.
Good morning, and thank you. Yes, we had a fantastic discussion yesterday. It was great to see everybody again. It feels like it's been forever. And I want to thank Susan for also obviously helping out. Next slide. Or do I do it? No. So here are the work group members. We had some new members join us, which was fantastic. So we had Sean McCandless, committee member, had been hanging out for a few meetings and decided to officially join us. So we want to welcome Dr. McCandless, and we had two other new members as well. So it was fantastic to have them and everybody. It was well attended yesterday. Next slide. So our questions, obviously some of them the same as the other groups, but and obviously our targets were more along the perspective of our participants being people involved both in the public health labs and systems. So what information would be most helpful from newborn screening laboratories related to the review of conditions on the RUSP, and how can we prepare newborn screening labs to collect and report this data? And I also want to say that obviously we have people in our group not just from the labs involved in the whole system, and a lot of that is informed our feedback. And you'll see that some of this actually does overlap with some of the other groups, not surprising. But our first bullet was the fact that we should, as we're looking at, especially if we're looking at conditions already on the RUSP, we should look at how well we are screening for each condition. And so there was discussion about actually having some objective performance metrics. What would we hope we would be achieving in terms of performance metrics when we're screening for these conditions? So, sort of having an idea about expected positive predictive value and negative predictive value. And I can't say that this would be the same for every condition, but maybe it should be. States could then look at their own systems and determine whether or not they're meeting the MPV and PPV for that condition. We should also be looking at evaluating and reporting the false positive rate and false negative rate. Obviously, many of the conditions already include a second tier test, but some of this information, has probably already been used for many programs to determine they need a second tier test, but it may also be a great way to look at some of the ones that are already on the RUSP. As defined and stated by some of the the two preceding groups, we must start with a good case definition. Can't calculate what's in the first bullet without actually stating that this is what we're doing these calculations for. So then obviously we can look at what each state is screening for and what else that they're finding. I think that, that this does differ by states, obviously based on what they may also define as, both case and what they're screening for, but important information to consider as you're evaluating your objective performance metrics. We also have to acknowledge that case definition could change over time and has for some of the conditions. So, we would have to figure out some way to sort of, revisit that as we go back and look at conditions on the RUSP. In terms of collecting and reporting data, everybody in the committee pointed to new steps being available in a place that we can use to collect the data, since data is already being funneled into that resource. Obviously, the difficulty for everybody always is that their LIMS are not interoperable with new steps. Obviously, there's always that data processing and input step that must occur, and obviously, is sort of a time-limiting step sometimes. So, and it's funny, we did, although it's been a while, I do remember that former committee members, Dr. Rinaldo and Dr. Matern, had actually presented to the committee, I forgot how many years ago. They published their own evaluation of mass spec-based screening and had actually suggested some metrics to evaluate screening, which I believe was PPV and false positive rate and detection rate, excuse me. So it's something that had actually been previously proposed by other members of the committee. So just wanted to mention that. Next slide. Second question, should there be more in-depth information regarding cost to labs for adding a new condition to the panel, or is there already enough information provided? So just remember that as part of each condition, there is a public health impact assessment. There's information survey going out, more detailed survey to programs that are already screening for that condition to get more detailed information, and a readiness tool in order to try to get information on, will your program need new instruments, employees, reagents, et cetera. I think the feedback I got universally from everybody is that, although some of this information has been helpful, we're still not getting the cost of the overall system. And I didn't put it here, but I think a lot of people have seen Susan's egg diagram. She had it yesterday in her presentation. That there's still a lot that we're not capturing in our assessment of the cost, and that we shouldn't obviously just limit it to labs, but the whole system. One suggestion, obviously we have. The survey is limited, get some information, get some readiness, and then get more detailed information, as I said, from labs who are already doing it. But, we have labs, and the survey goes across all groups, but you're going to have some labs that are going to be more ready than others. And it might be really useful to use more of what we call a bucket approach. With presenting and breaking down the cost to the system by states that are starting at different levels of readiness. And I think back to like when we brought on SCID and the idea about adding molecular testing. Some states were much more ready than others, and it might be really informative to the committee if we actually were able to look at what the difference might be in terms of time and cost if we sort of consider that and stratify by different levels of readiness. But I definitely think we're just hoping for although we also acknowledge that it's hard, it's not easy, that we need a more the estimate of the cost needs to involve more than it is right now. Next slide. Are there any other considerations for enhancing either the nomination process or review of conditions on the RUSP? And unfortunately, we didn't have as much time to talk about this one once we got to the other two, and have some overall, I think one of the things that that we heard was they really thought that both for our committee discussion as well as something that really helps state programs is when we have a better definition of the condition under review for the committee as well as I said, the states going forward. And the example was the SMA definition because it actually described what we were looking for. I think the comment that I received and wanted to pass along was that the information that we've been getting from as part of the evidence review process has been extensive and very thorough, and that the feeling was that it will benefit from the proposed enhancements that Alex talked about yesterday. So, we didn't have much else besides obviously even talking about the costs on the previous page about information about the evidence review, for example. Something that kept coming up, and I think that we were talking about, we wound up getting on the topic about reviewing conditions on the RUSP and the process of potentially, reviewing and removing, because I think that's something that people are interested in that discussion, and obviously some of them have also had these discussions in their own programs. And a lot of people thought that, one of the interesting things that they've noticed is confusion about what the RUSP is. Many interpret that the intent to screen is for both primary and the secondary targets on the list. However, the RUSP is the list of primary targets, and obviously the secondary targets are ones that are often also screened for in that process. So there are those that have the RUSP or the requirement to screen for the RUSP in state law that is then interpreted to screen for primary and the secondary targets. The discussion is that for some programs it has been, they have actually been able to talk to their programs about removing some secondary targets from their screening program, and SCAD was given as an example, and sort of educating the people in their state and their clinicians and their programs that they had the flexibility for the secondary targets. So we had several suggestions. People were very interested in this, and some of the suggestions were education for everyone in the system. So this is states and clinicians and about the secondary targets, and one person had some pointed suggestions for the wording and display of the RUSP on the committee website, and feeling that it added to the confusion. So, this was just an interesting discussion about some states already taking on some of their own initiative to review secondary targets and remove them from the state program. So, that came up multiple times. So I think that that's it for us. As I said, it was a very fruitful and enjoyable discussion, and thank you very much.
Thank you, Dr. Kelm. I think one clarification, and this was something that I had asked about, as we talked about reviewing conditions already on the RUSP, that the committee would be considering both the primary and secondary targets, and as we go through this process. So I think, your work group suggestions are very helpful as we think about how things are presented on the website and confusion about that, because I think a lot of people do have confusion.
Mm-hmm.
All right, so we heard some very interesting ideas discussed by the work groups. I will now open the floor for discussion. Committee members will discuss first. Excuse me, followed by organizational representatives. As a reminder, please use the raise hand feature in Zoom when wanting to make comments or ask questions. When speaking, please remember to unmute yourself and state your first and last name each time you ask a question or provide comments to ensure proper recording. Okay, sorry, let me just get my list here so I can see. All right, Jeff Brosco.
Thank you, Jeff Brosco, committee member. So Kelly, I want to come back to something you said about the cost estimates and how difficult things can be to gather. And I'd like to maybe separate out information that we gather from that 9-month period that allows us to make a decision about adding to the RUSP and information that might come afterwards. And I'm actually going to say something nice about Scott Schoen. Don't hold me to this, but one of the things we did in Florida when we got to that point where we decided, yes, we think, SMA, for example, had been added to the RUSP, it was very useful to get a state-specific estimate of what it would actually cost, and not just cost in terms of financial, but also how many neurologists do we have and what access do we have to this and that, and what would it really take for the Florida lab to be able to get up to speed. And it was really helpful for things like how much money should the state legislature budget in order to add SMA. So even things that may or may not be sort of specific to the RUSP and whether it should be added or not, a lot of that information post-RUSP might be really useful as states are trying to actually implement. And so anyway, I said something nice about Scott for a change. There you go.
May Baker.
Oh, hi, everybody. Very interesting. I listened to the work group report. I did pick up one recurrent thing is we talk about RUSP conditions. And Dr. Powell also emphasized that. I think with everything we need to, go to the fundamental thing is when we nominate condition, when we put in the RUSP, what's our intention? The condition we intended to screening for, and many people, I think every work group mentioned that is, what are we screening for? What we also pick it up. I think if we do the review, I think to me, is a more fundamental thing. Then I hear so many people have interest in and knowing we have concern exist. I'm wondering the chair of the committee can think about have a work group, the laboratory standard group, and also maybe education and group somehow, some way, systematically to review that. I think RUSP been using for quite a while now, and I think has been, benefited in so many ways. And on the other hand, what's the certain part do we need more state clearly and educate people really what's about? I think interesting, and I do believe like SCARED and SMA really give us the way to think things like the marker, what the marker give to you and leading the condition that you can kind of group them. And I think about the tandem aspect assay. If you think about the condition and think about the action sheet, actually in the action sheet, SMG developed, they do state all the markers. So I think we do have some material and the baseline, we can do a little bit more systematic review. And at some times, like we can update our app website, defined, and I think it will be useful. Thank you.
Thank you. Scott Schoen.
So first of all, obviously, thanks to Jeff for saying something kind. I appreciate it. But I would say that work with the Florida Advisory Committee, I think it's another example of what I was talking about yesterday on the cranes and the freight train, right? So to go back to that metaphor is that Florida has the law about having to onboard conditions, but their advisory committee is that final arbiter and wanted a robust evaluation specific to their state, taking from lessons from the RUSP, but also any states that have then implemented. And so I think that so they hired a group to come in and evaluate their state and provide that overall system impact for Florida. And so it takes sort of APHL's national look at the PHSI and brings it more local. And I think there's an opportunity. I mean, we always say that if you've been to one state newborn screening program, you've been to one state newborn screening program. But I do think that we do in general have buckets. So there's not 50 solutions. There's not one solution. There's something in between it. So I think there's a lot to gain. Maybe HRSA, we can think about, the committee can think about working with HRSA on a program to help sort of bucket out, as Kelly was saying, around where states are. So there's a better gauge as opposed to the broad whole national view, but based on resources, coming from Jersey, reflecting on how resource rich we were with our metabolic geneticists and our endocrinologists and our pulmonologists compared to other states. And I think that there's a real need to assess that and evaluate that when we're looking at these impacts. And so just to say on what Jeff has, I think that programs need that crane to help do that assessment for them as they bring on conditions.
Thank you. Robert Ostrander.
Sorry, I had to unmute. Robert Ostrander, AAFP org rep. I've got two comments on the subjects we talked about. One is just to fill out on Jeff's amazing brief summary of our work yesterday. When one of the slides said one of the things we should measure in the patient care realm of longitudinal follow-up is the patient getting care in the appropriate setting. But one of the things that I think is important at the nomination level is not, are they getting care or is there capacity? Because we're not going to know that. But what is the vision of longitudinal follow-up care look like? And it seems, at least my experience with I'm on the advisory committee over the years, is when we look at a condition, we have a pretty good picture of what is going to be done if the condition gets added and implemented for those children in the first few months when the intervention is done. And we're starting to get a sense for the conditions where there's a late onset form, how the surveillance might happen. But I don't always think we have a very good picture of what this is going to be a vision, because it won't have evolved because the condition hasn't been around long enough. But they're the pilot studies. There will be some kids that are out there. What is care going to look like at the 2-year mark and at the 5-year mark? And not so much is the kid getting the care, but at the time of nomination, what do we imagine that might look like? Does we imagine it might look like? Again, my bias always is a combination of medical home and specialty center, but a little more specifics to the condition. So I would like to see part of the nomination application, and not a thumbs up or thumbs down, part of the nomination package indicate that there's been some thought given into that. Once we treat these children, what will their care look like 2-5 years down the road? And then the other issue is this concept that we need to look at harms on the review side when conditions are brought back up, because that ratio may change because of all the milder cases that get detected once we do universal screening, et cetera, et cetera. And all I wanted to point out is a suggestion to the committee that as we look at this, that we get some input from the USPSTF folks. And I know Alex sat on that for quite a while, Alex Kemper did, because they've got a system in place and they're pretty expert at looking at their public health recommendations periodically and then doing revisions. And a lot of that has to do with harm benefit reviews and sort of putting the different harms in different boxes, from the economic to the psychosocial to the actual medical harms versus the benefits. And it's something we sort of struggled about in our work group yesterday was, well, there's all these different kinds of harms, and how are we going to do this? I just want to suggest that the committee, if we decide to do something with this committee, tap Alex and the USPSTF and learn about their process, because this is something they've been doing for years, and it's very much analogous as a public health recommendation that once it gets done, new information arises. Thank you.
Thank you. Very good suggestion. Deborah Friedenberg.
Hi, good morning. I just want to expand a little bit on the previous comments in terms of what we think about with follow-up for these conditions. And one of the things I just want to expand about is that when we talk about milder conditions and think about what the implications are, many of what we call, quote, milder conditions have a significant impact for that particular child's medical care and morbidity and hopefully not mortality with them. But something we're calling mild really does require a lot of medical intervention, and it requires care as well. And I'd like us to keep in mind that the spectrum of disease that we clinically classify as mild may not be mild for the medical care of that family and that child as well. And so just when we think about the spectrum, and I also do really agree that we need to think, when we think about long-term follow-up, we, talking through the lifespan, we do need to think about a system-wide approach rather than just the newborn screening program approach. And I think that's been really evident in everything that's been presented and said, and would like to continue to think about as new conditions are being proposed. We start, or in more depth, start to think about what that system-wide approach would look like, and not just a programmatic approach.
Deb, I hate to put you on the spot, but could you give us an example? I'm sure you have some in mind when you're talking about, milder conditions that really have a significant impact on that child's medical care.
Well, I mean, you take MPS 1, some of it's mild, some of it's not, and some of it's requiring significant treatment with that. For CAH, we know there's an ongoing discussion about what non-classical CAH looks like and the impact and treatment that's needed in childhood, maybe not exactly neonatally, but that continues to be needed. And if we just go back to XALD, we consider the mild variants, those that have onset later on, but it impacts their life and their quality of life, as well as the medical care that's needed if you're going to become, because of your motor issues, become wheelchair bound or whatever. I mean, those are all significant medical issues. Mm-hmm. And so, in the diagnostic odysseys that people go through. So those are just some things off the top of my head. But, mm-hmm. As we all know, on the metabolics too, they're also, we can consider something mild, and yet the child can be in the ICU being resuscitated from a metabolic decomposition with something we call, quote, mild, like a cobalamin C or something like that. And I know that's a secondary, but, we say it's mild, but it can present and be as life-threatening as some of the other conditions as well.
Mm-hmm. Thanks. Anna Marie Saarinen.
Hi, thank you, Anna Marie Saarinen, committee member. I appreciate what Deb just said. I was kind of leaning into that a little bit in my my comments. And again, I have a little bit of a lens with CCHD and knowing that it's the outlier and it just has different considerations. But that said, I think a lot of what you were just saying, Deb, is true for both of the point of care screenings that are non-blood spot at this point, and how we would look at maybe things like that could come up in the future, right? So a lot of these kids would require monitoring over time. There's a huge variation between a baby that's going to need to undergo cardiothoracic surgery in the first few days after being picked up by a newborn screening program, and a baby that has maybe still falls into the CCHD or the serious congenital heart disease category that just needs to be coming in every 2 weeks, every 4 weeks for evaluation, may not need surgery until they're 4 months old or 6 months old. Either way, it's still critically important, and it leads into sort of that other piece of what Dr. Kelm was talking about on secondary conditions. And I know we've had this discussion before, and I think May Baker has some very articulate perspectives on this, but well, actually a lot of people in this group have articulate perspectives on this, but the secondary conditions, the ongoing sort of lack of clarity of how they fit into our evaluative and our framework for data collection and tracking is still it's a little bit of a point of frustration, and I don't know if it's because it's just too hard to tackle that within one of the work groups to advance what would be a more formal recommendation of how the committee thinks about that and how it thinks about it, not just when we look at the conditions, but after the conditions are already on the panel. But I think we all realize that just the definitions of what those secondary conditions are and how we're categorizing things from false positives to true positives for a non-target condition or a secondary condition is, to me, it's just so mission critical to a public health program. If we don't get this right, how do we report out to the rest of the world, whoever they may be, that we've been successful or moderately successful or a failure? Because all of those things could be true, under which different folks interpret how to report on what's a positive screen or what's a false positive screen or what's a true positive for a secondary condition. So thanks for letting me share that and for all the hard work that all three of the work groups have done here.
That's really a key point, isn't it? Jennifer Kwan.
So I think I'm always kind of curious when people talk about harms and reviewing programmatic responsibilities and scope, like sort of the specifics they have in mind, because like everyone else, I think I'm sort of driven into making comments based on my specific experience. And I think that that gets difficult. And one of the things it reminds me of is that I wonder if we could come to some consensus about what the scope of responsibility of the advisory committee's activities would be. So it was interesting listening to Kelly's talk about sort of the laboratory perspective, because of course that's where newborn screening starts. That's where we think of the home of the public health enterprise of data collection and screening and reporting out the results. And then it gets into the education phase, and then that's where we know that there are some breakdowns in terms of how people understand the information they're being given. And when I say people, I mean providers and patients and their families, in terms of what constitutes a positive screen, how to react to it, how to implement treatment. And then I think the long-term follow-up and treatment group has such laudable ambitions. We want to implement early care, knowing that many of the programs result in us not really implementing early treatment. Like the early care doesn't necessarily involve an initial treatment. It involves early initiation of surveillance that can have considerable impact on families, as I think Deborah Friedenberg was alluding to, but not necessarily necessarily actionable results. Like I think for families and providers, it can feel very frustrating getting into this cycle of surveillance. And so when we review these programs, and I think it would be worthwhile reviewing them, I think we also need to keep in mind just how messy it gets. And I think that some of what we're looking at in terms of long-term follow-up and treatment perhaps needs to really be in the realm of specific specialists and specific groups and advocacy groups. And so I think for me, it's more just trying to frame how we are going to go about looking at these various disorders and deciding on how effective or how successful we've been.
Thank you. Thank you once again to all the work groups for your very valuable feedback. It's much appreciated, and to all of you who participated in this discussion. We'll now take a break since we're a little bit over, let's say 11:15. We will reconvene Eastern Standard Time, reconvene at 11:15. Thank you. Welcome back, everyone. If I could just ask the committee members, if you've rejoined, if you could start your video. That way we won't have to do the full roll call again, but we'll know that you're present. Thank you. For our last session of this meeting, I'm pleased to welcome a panel of 4 presenters who will discuss innovations in long-term follow-up. Dr. Jeffrey Brosco will set the stage in his discussion of long-term follow-up as a key component of ensuring the best possible health outcomes for children and families identified through newborn screening. Dr. Brosco completed an MD and a PhD in the history of medicine at the University of Pennsylvania. He served as chief resident after training in pediatrics at the University of Miami, Jackson Memorial Hospital. And he is board certified in pediatrics and in developmental behavioral pediatrics. Dr. Brosco serves as chair of the Pediatric Bioethics Committee at Jackson Memorial Hospital and associate director of the Mailman Center for Child Development. Dr. Brosco has had a series of leadership roles in the Florida Department of Health, including serving as the Deputy Secretary for Children's Medical Services from 2016 to 2018. He is now Florida's Title V Children and Youth with Special Healthcare Needs Director. Following Dr. Brosco, we'll hear from Carol Johnson, who will provide an overview of APHL's Long-Term Follow-Up Task Force's Long-Term Follow-Up Landscape Survey. Carol Johnson has been the Iowa Newborn Screening Follow-Up Coordinator since 2011. The program also screens and provides follow-up for 3 other states, Alaska, North Dakota, and South Dakota. She coordinates the Quad State Initiative and sits on the Newborn Screening Advisory Committees for Alaska and North Dakota. Ms. Johnson has co-chaired the APHL Short-Term Follow-Up Work Group since it was developed. She is also the co-chair of the APHL Workforce Task Force Work Group since its beginning in 2019. We will then hear from Dr. Mary Schroth, who will discuss long-term follow-up for individuals identified with spinal muscular atrophy. Dr. Schroth is the Chief Medical Officer at Cure SMA, where she leads the SMA Care Center Network and SMA Clinical Data Registry to collect real-world evidence about care and treatments for people living with SMA. She also advocates for the implementation of SMA newborn screening with state public health labs and officials and healthcare professionals across the U.S. Dr. Schroth is Professor Emeritus of Pediatric Pulmonology at the University of Wisconsin School of Medicine and Public Health, where she provided care to children with neuromuscular disorders for 25 years. Finally, we'll hear from Dr. Amy Brower, who is a medical geneticist at the American College of Medical Genetics and Genomics in Bethesda, Maryland, and is the co-principal investigator of the Newborn Screening Research Network. Dr. Brower directs a team that develops informatics platforms, resources, and tools to collect, analyze, visualize, and share longitudinal clinical and genomic research data to better understand genetic disease across the lifespan. She has a background in medical genetics, genomics, informatics, FDA submissions, newborn screening, translational research, molecular diagnostics, and bioinformatics. She was a member of the Human Genome Project and International HapMap Project and developed molecular diagnostic and informatics platforms over a decade of work in the device industry. Dr. Brower was an inaugural member of this committee. She is the parent of a son with severe combined immunodeficiency. So next I will turn it over to Dr. Brosco.
Thank you very much, Dr. Powell. My job in the next 15 minutes or so is to try to sum up a lot of what we talked about yesterday in the context of nominating new conditions, and then a bit about what our work group has been working on, which you heard just an hour or so ago. And I'll make a couple of comments on specific items that I think are really important for us to look at, and then set the stage for the rest of the panelists. Next slide, please. So just a reminder that this topic is such an important one that we've had a work group working on this for well over a decade. And I won't go through all the details of this because you heard me say all of this at 10:15 this morning, but just remember that our work group is charged with looking at barriers, recommendations, and responsibility. And really, we've been most interested in longitudinal follow-up over the last decade because that's where a lot of the action is. And just a reminder about language, I'm using follow-up to include treatment and implied treatment, and trying to use longitudinal rather than long-term because it seems to be more Catholic. And then you see just those publications that we've been working on in the treatment follow-up work group to make sure that we're following that sort of pattern of setting out what the broad ideas are and then looking more and more closely and getting down to specific quality measures. Next slide, please. And this is the framework I just showed us an hour or so ago that really lays out neatly all the things that we need to consider in any kind of network system that looks at longitudinal follow-up. Next slide, please. I do want to emphasize a couple of these points, although you've probably heard me say them yesterday morning and this morning, that this idea about access to treatment, I'm going to come back to in a few minutes, about equity and where those potential barriers are, is really an essential one. And we see this play out at both the national and the state level as we're trying to decide what to add to the newborn screening programs. We've talked enough, I think, about outcome measures and population level data, but we'll touch on a few of those as we talk about how we might actually implement that. Next slide, please. So I just want to dig into this federated system idea a little bit. And again, we start with the premise that the United States of America has a very, what's the right word, variegated approach to healthcare systems. In some ways, newborn screening is an anomaly. It's one of the very few things where we try to set national standards and states implement it. And that's really remarkable for medical practice and healthcare practice. We don't have, we're not Denmark or Sweden where we have national data sets so we can keep track of folks. So it makes it really hard. So this idea that the different players could work together and create this federated system so that every child identified with a newborn screening condition gets high quality, evidence-based, family-centered care is kind of our goal. So there's different ways of thinking about this, and I'm not going to say too much now because in some ways this is what the rest of the panelists will talk a lot about. So whether it's the LPDR that NBS-TRN has put together, we'll hear more from New Steps program through APHL, HRSA obviously, and there are other systems and models out there. The NIH has its Rare Disease Clinical Research Network, and Region 4 for a long time has been sort of following up on errors in metabolism. So there are systems out there that work within newborn screening world that we could tap into. And obviously the electronic health record and artificial intelligence are moving forward in fits and starts. And this is a way that we could create a more interconnected information system that can answer a lot of questions. Obviously, we're not there yet. We're frustrated by a lot of this, but it's possible. With enough financial resources, anything is possible. We are looking at, our work group has talked about certain kinds of federal state partnerships to make that happen. I'm going to talk more about equity in a second, but I do want to say this idea of defining who's responsible at each stage, this roadmap idea. If you go to the next slide, just to kind of give you a sense of the players, the first thing to keep in mind is why do we need a federated system? Because there are different goals. And I mentioned this morning, that some people are most interested in the research part. We want to know, did something work? Is early identification through newborn screening, does it truly lead to improved outcomes? Or if we just discovered most of these kids clinically would have been about the same. What else can we learn from changing the natural history of a condition by newborn screening? So lots of research questions. The idea of quality improvement and assurance happens at a lot of different levels, and I'll talk about the players in a second. But one just simple question is, did this child, we identified him, did he or she get treatment? And what was the outcome? And it could be very simple things like, yes, they got treatment and they are still alive at age 5 and they do not require special education at age 10. It could be simple kinds of data points like that. And then the idea of what's the impact of the newborn screening program on our condition. We implemented newborn screening. What kind of impact did it have at a broad level? Can we see that there are decreases in the number of children who have long-term effects of newborn screening conditions. And then the most obvious for most of us is the clinical care. So how is this particular child doing? Is he or she getting what they need? And what's their long-term prognosis? Next slide, please. Then if you think about the different players, there are the different groups that have interests in this group of children. And it's helpful, I think, to see the newborn screening population as part of the larger subset of children and youth with special healthcare needs, which is of course part of the larger group of all children. So if you look at, there are 4 million children per year born in the United States, there's 80 million children or so. Children with special healthcare needs constitute about 15 to 20% of those children, depending how you define it. That's any child who has greater than usual need for medical, social, educational intervention. And then newborn screening conditions are kind of a subset of that, and probably around maybe 1 or 2% of kids, depending again on how much you include as newborn screening. And so different interest groups might be interested in different groups of children. So Maternal Child Health Bureau, Medicaid, state departments of health, we are worried about all children. We want to make sure every child gets the care that they need. The state Title V programs, children in special healthcare needs programs, we're particularly interested in that second sort of circle of 20% of children that have a special healthcare need. Newborn screening programs, obviously kids who have a diagnosis in the newborn screening program. Clinicians, researchers, family members tend to be focused on that particular child in front of them. But of course, many feel much greater responsibility to the larger population of children with newborn screening conditions. Next slide, please. So when you put that together, we say, well, what's the role of the advisory committee? What are the things that we would think would be most important? And I mentioned this earlier this morning, our first sort of pass at this from the work group's point of view is that we could use the predictions, those predictive models from the evidence review as one way of thinking about the benefits of the ratio of harms and benefits. I'll come back to equity in a minute. May and others have talked a lot about the case definition and the change in how we think about each disease once we start doing newborn screening. There's been a lot of talk in the last day or two about harms. I'll point out that Aaron Goldenberg has a couple of really good papers on harms that sort of lay out some of the details and ways of thinking about that in categories. And this idea of barriers, we want to come back to after we hear from the New Steps folks and from LPDR to see how barriers to treatment might fit into the systems in place that are already there. Next slide, please. All right, so some of the new stuff now. I mentioned this earlier. If you look at equity in newborn screening, that is one of the true values in terms of diagnosis of newborn screening. And a few of us had a paper a couple years ago that looked at this, and Scott Gross was an important part of this. And what we said were, for example, if you look at SCID, in the years before newborn screening in California, 80% of the children who had bone marrow transplant for SCID were white non-Hispanic. In the 2 to 3 years after newborn screening started, it completely reversed. So 80% of children who got treated with a bone marrow transplant were either Black or Hispanic. And what we had thought was a genetic disease of white non-Hispanic families turned out to be entirely about access to diagnosis. And it's a really good example among many of how once we have true equity, universal newborn screening, that we have a real change in how well populations are doing. The problem is that although we've done fairly well on the diagnosis side, we have not done so well on the treatment side. And Alex Kemper and Scott and Colleen Boyle and I recently wrote about this and talking about the many ways that we do not have equity when it comes to things like getting antibiotics for sickle cell disease, getting treatment for hypothyroid or PKU. And the figure there is one you've probably all seen. Maybe one of the ways to think about it is on the equality side, where you see those 3 square blue boxes at the bottom. That's kind of where newborn screening programs are in terms of diagnosis. We're really good at that sort of every single child getting the diagnosis from newborn screening. On the right side, really the equity side, is probably where we'd like to get for treatment. And that is, could we imagine that the boxes multiply to make sure that every child reaches that apple, the apple being treatment? Next slide, please. So I mentioned this morning that when we talk about equity and access to care, we should probably use this broad definition from the WHO. Just to mention, I know this is a little blurry, I apologize for that, I did it last minute, but availability is the idea that whatever we think is necessary, whether it's a medication, a device, a treatment, is actually physically available to folks. And affordability is sort of obvious that people can afford it. Accessibility is Geography is one of the things, but it also could be about disability. Appropriateness is whether it's scientifically valid and meets a local need. Acceptable to the cultural beliefs. So you can think about, for example, PKU foods and whether that works for different populations. And quality, that there's some way that we're keeping track of it. So we would like to have a pretty broad idea of thinking about access to care. And next slide, please. And then just in the last 12 hours, I had a really interesting email exchange with Marianne Sorensen and Scott Gross. And it was important enough that I thought it was worth just quoting at length, and they gave me permission to do so, because it's a really neat description. So this is Marianne, and she's saying, sometimes you can't have everything in place to start, meaning equity. I think that you used an example, and she's talking about me, about a situation where only half the kids get access to treatment. And just to back up for a second, this was a question about, parents saying, well, if only half the kids can get treatment for SMA, that's worth it, because those half children will do well. But she said the conditions are various condition specific, and then she says, of course, children should have access to treatment for identified conditions. But access cannot mean exactly the same thing for every baby and family. A family from Fargo that has to travel to Minneapolis for their child's treatment and follow-up. The specialist has a very different experience than I do. She lives 12 miles from the University of Minnesota. People lose their livelihoods over this thing. My husband and I had thousands out-of-pocket costs to stay in hotels and motels during Eve's heart surgeries. That would be completely impossible for many families. Yes, what I'm saying is we can only try to level the playing field. It cannot be an excuse to delay implementing something that can help a portion of babies until the rest of the investments in infrastructure and more equitable access can happen. So right there, I think is a really good statement of one position on the equity question, which is we can't wait for a perfect healthcare system in a perfect world. Sometimes we need to start somewhere, and just starting can then spur equity. So it's a really, I think, heartfelt and eloquent description of that position. Go to the next slide, please. And then Scott weighed in and sort of emphasized what Anne-Marie was saying about the cost of care being a lot of things, not just medical costs, but transportation, lodging, childcare, loss of earnings. And he also points out the systematic things, that lower SES is associated with these sort of barriers. There are psychosocial barriers, there's lower health literacy. And he talks about trust in our healthcare system and communication differences. And there's no doubt that both implicit and explicit bias are rife in our healthcare system and reduce access to care depending on race, ethnicity, language, social class, a whole range of things. And he concludes, as I think a lot of us would agree, that disparities in access are unfortunately the norm in this country. Last couple of slides, next slide, please. And so I sort of responded that we can't expect newborn screening programs or researchers or clinicians or families to solve all the problems of the US healthcare system or issues of racism or inequality. Quote, on the other hand, newborn screening is a public health program. So I think that implies a greater obligation to meet the treatment needs of infants and children. It's sort of this idea, don't tell me my kid has PKU and then you can't help me with formula and foods. It doesn't really help me if I can't get what I need from my child. So while we can't expect to solve all the inequity in the US with newborn screening, we probably need to go a bit further than we do now. So this is just trying to frame in some ways the real issues in the equity question. It's not as simple as it looks. And it does have some impact on us as we're thinking about how to expand newborn screening to new conditions if treatment is really not available to every child. Is it okay to go forward if some kids benefit, meaning some kids won't? Next slide, please. And then just sort of to conclude and set up for the next group, at least from the work group's point of view, we still have the same charge to look at barriers, recommendations, responsibility, and some potential next steps that we can offer to these questions are obviously continuing to work with the advisory committee on the nominating process change that we've been talking about yesterday and we'll keep talking about. And then really importantly, and this fits in with what the other panels are going to talk about now, is what would that roadmap for a federated system look like? We're not going to have a single electronic health record or data system anytime soon, but how could we work together to sort of patch something that works? And that would include thinking about what conditions to include and when, what information is most relevant to the secretaries, to the advisory committee, and who's responsible for adding that information. And then lastly, sort of following up from those quotes from Anna-Marie and Scott and me, we need to keep discussing this issue about access and equity. It's obviously a critical social issue, and we need to think how this fits into newborn screening policy and practice. Thank you.
Thank you, Dr. Brosco. We're going to hold questions and comments until all the speakers have gone. So we will next hear from Carol Johnson.
Thank you, Dr. Powell, and thank you to the committee for inviting me to speak with you today. So today I'm going to talk about the New Steps Long-Term Follow-Up Task Force and some of the deliverables that we've been able to accomplish so far. And it does fit very well with what we've been talking about already. And thank you, Dr. Brosco, for setting the stage. Next slide, please. So in May of 2018, back when we could still meet face-to-face, the APHL hosted a national short-term follow-up stakeholders meeting for to present a forum for follow-up staff to be able to discuss solutions to some of the common issues that we had. During this meeting, the short-term follow-up work group decided to create 5 distinct task forces to address some of the needs in the newborn screening community with a focus on long-term follow-up. We did create a long-term follow-up task force, and we asked them to address the role and scope of newborn screening programs in long-term follow-up, to assess the effectiveness of long-term follow-up, and to justify the implementation of long-term follow-up with program administration. Next slide, please. The next several slides highlight some of the deliverables that we've been able to accomplish so far. Next slide, please. So the long-term follow-up task force began to meet monthly in January of 2019. And after much discussion, because this is a complicated situation, we decided to focus on 2 projects. One was to develop a working definition of long-term follow-up, and the other was to assess the long-term follow-up landscape across newborn screening programs. We used this working definition to guide us to develop the questions and the data elements for a survey that we sent to newborn screening follow-up programs. Next slide, please. We called this the Long-Term Follow-Up Landscape Survey. It was 20 questions long. We welcomed responses from multiple entities per state. We distributed this to 76 distinct contacts and 54 distinct states or territories. This survey included newborn screening staff from hearing, CCHD, and dry blood spot screening programs. And ultimately, we received 42 responses for a survey completion rate of 55%. Of these, 32 of the responses were complete and 10 were partial responses. And we excluded those partial responses from the data analysis. Next slide, please. We chose to highlight some of the questions for this committee today. Here is one of the questions that we asked was, what is the current state of long-term follow-up in your state? We had some that said that was fully implemented, partially implemented. Half of those 32 surveyed programs stated that they do at least some long-term follow-up activities, while you see there is a 41% response rate that they have no plans to implement a long-term follow-up program at this time. Next slide, please. The next question we ask is, how are you funding your long-term follow-up activities? We had several responses that they use their newborn screening fee. Some are using grant funding, some are using state funding. Over 50 of the respondents that said that they're using their newborn screening fee also reported it as their only funding source, in higher proportions than those who reported that they use grant or state funding. That was at a 38% and 50% respectively for the grant and state funding sources. Next slide, please. Then the next question, maybe the most important question, was what types of long-term follow-up activities are being performed? And you can see here that there are multiple answers, and these are all valid long-term follow-up activities, of course. But I want to draw your attention to the first 3 responses. When you talk to follow-up personnel, they'll tell you that, well, long-term follow-up is this, or long-term follow-up is that, because we still really don't have a true formal definition of long-term follow-up yet. And so many say that it's the data collection from the clinical providers. Others will say it's facilitating clinical care follow-up, while others say it's connecting individual families to services and support. Again, all of these activities that you see on the grant are important. And in fact, 42% of our respondents stated that they do actually more than 4 distinct long-term follow-up activities. Next slide, please. These next 2 graphs illustrate what percentage of conditions on your newborn screening panel receive services or activities. And you can see there is some differences based on condition, and we're going to talk about that more in a little bit as well. And then the purple graph shows what percentage of individuals identified through newborn screening receive long-term follow-up services or activities. And it's a slightly different response there. Next slide, please. Then we ask, what are you doing with this data that you're collecting? And several responses said that they use this to track the babies that are lost to follow-up, which is actually one of our quality indicators, that they track clinical outcomes of patients, that they assess the needs of individuals and families for services, that they use it to evaluate the performance of their providers. And one stated that they use it to conduct research specifically to look at the cost-benefit analysis of testing. I thought it was interesting that the top 3 responses here do somewhat correlate with the top 3 responses of the long-term follow-up activities that are being performed. Next slide, please. And then we ask, how long do you conduct long-term follow-up? As you can see here, there is a wide variation of length of service based on the condition. And we highlighted 6 different state responses just to really illustrate that point. And even though we've already heard about this is a system and it should be a system for a lifetime, only 25% of states are conducting long-term follow-up for the lifetime of the individual. Next slide, please. Then, in addition to assessing the current state of long-term follow-up activities, we also wanted to be able to identify the challenges and barriers that exist to the implementation of a long-term follow-up program. As you can see here, many different responses, and it shows that we have some work to do in this area. Standardized recommendations, definitions, and guidelines were selected in over half of the responses. And I should state here that they could pick more than one response. And although this doesn't have a slide, we also ask the people that we surveyed what new steps could do to provide assistance in developing or helping to maintain a long-term follow-up program. Next slide, please. We allowed the individuals that we surveyed to comment, and we pulled out 5 responses that we thought you would find interesting. Many states expressed frustration with the lack of support for implementing or expanding their long-term follow-up from program leadership. They're telling us that program leadership just does not consider this a priority. However, those of us in this meeting today and those who work in newborn screening know that long-term follow-up is a very critical component of the newborn screening system. And in fact, this committee back in 2008 stated, all of the conditions identifiable through newborn screening are chronic and therefore require medical care and intervention throughout the affected individual's lifetime. Next slide, please. So what is APH's role in long-term follow-up? Next slide, please. Again, I would draw your attention to a quote from Dr. Alex Kemper et al., also from 2008, that basically says, newborn screening is intended to be comprehensive, including not only screening and diagnosis, but also long-term follow-up care through the medical home. So interesting that Dr. Brosco, you're right, that everything's been set for us already, right? In addition to this, the task force plans to develop a manuscript on the publication of, for publication on the status of long-term follow-up currently to the International Journal of Neonatal Screening for their special edition for follow-up. And in addition to that, we also hope to develop a position paper identifying a role for APHL in long-term follow-up, to develop a definition. Remember, I've told you that there still really isn't a set definition. To develop that definition for long-term follow-up and or to identify those key components of a long-term follow-up program. We're also considering developing a long-term follow-up fact sheet for programs to use to demonstrate the importance of long-term follow-up to their leadership, and also to offer technical assistance to those programs who want to develop and implement a long-term follow-up system, as well as those who need and want to maintain and enhance their current long-term follow-up program. Next slide, please. Then what is this committee's role in long-term follow-up? Historically, this committee has provided insight that has really enhanced and improved state newborn screening programs. And this is an open-ended question to you. We would be happy to hear any feedback and suggestions from this committee. And then next slide, please. Last but not least, some acknowledgements. You can see here the various participants in our work group, which is continuing to work. Big thank you to Joanne Bolick from Arkansas and Lonnie Cully from the Washington State Newborn Screening Program for co-chairing this work group. They have done amazing work and they believe in long-term follow-up and they have been inspirational to us. And thank you to the APHL newborn screening staff, to those individuals who did the data analytics and the lovely graphics for us, to Erin Darby, who is our lead. She is fantastic. She keeps us organized, she keeps us on task and makes sure that we deliver a quality product. And last but not least, Jalili Ojodu and Sika Singh for their ongoing and continuous support of newborn screening programs. I don't know that the APHL newborn screening staff realize how much that is important to those of us out here in the state programs. Thank you for your time, and I appreciate the chance to be able to present this information to you today.
Thank you, Ms. Johnson, for presenting this information. It's really helpful, and thanks to the APHL for all the work they're doing in this area. Next, we will hear from Dr. Mary Schroth.
Thank you. Can you hear me okay?
Yes.
Perfect, thank you. Thank you for this opportunity to present to the group our work at HRSA. Next slide. Just to give you a little bit of information about our organization, HRSA is a nonprofit patient advocacy organization, and we fund and direct comprehensive research that drives breakthroughs in treatment and care. Our focus, though, is supporting families, patients and families living with SMA throughout the U.S. The organization began in 1984 as Families of SMA and then changed our name to HRSA. And we have many, many people on the ground. We have 36 chapters across the country that are volunteer-led. And that is our website. Next page, next slide, please. So I wanted to begin by just providing where we are currently with SMA newborn screening across the US. And I apologize if you have gone through this previously, but I just want to set the stage for what I'm going to talk about. So as you probably all know, we're at 33 states that are screening for SMA, and that includes those that are permanently implemented and those that are conducting pilots. And based on some of the modeling that we've done at HRSA, that represents a little over 68% of all infants in the US currently being screened. And as you all know, SMA was added to the RUSP in 2018. Next slide. As part of our work at HRSA, we advocate for implementation. We also support state labs. We reach out to the state labs to say, hey, we're here. We've got materials to share with you. Please use us. Please tell us how we can help. Please tell us how we can work together. One of the things that we do is we also ask states to share with us the number of patients that they screen and the number of positives, positive tests performed or potentially the screening tests that they do. And what we've learned so far, we've had 25 states respond to us. And we recognize that there are 17 states were added in 2020, so many of them are just beginning to collect that data. Approximately 2.5 million infants were screened since January of 2018. And among those screened, 173 infants were identified through newborn screening. And of those, just side note, 108 families contacted HRSA after diagnosis. And this represents an estimated incidence of 1 in 14,000. We know that the current literature and standard that we're up against, or that we all accept, is 1 in 11,000. But what we're seeing with this early information, with about half states reporting, is 1 in 14,000. And we could go into reasons for that. And just so people know, we do not reach out to families. Families contact us. We ask our providers, we ask state labs to share information, and then families reach out to us as they are ready to do that. Next slide. SMA, as you all know, has changed dramatically over the last 10 years with clinical trials of the new treatments, and in particular trials that involve pre-symptomatic infants. Newborn screening for SMA is essential to achieving best outcomes for this truly devastating disorder. In this slide, I'm sharing with you outcomes from the nusinersen pre-symptomatic clinical trial that demonstrates that children with 2 copies of SMN2 can achieve motor milestones not previously possible without treatment. And children with 3 copies are able to achieve all motor milestones. In comparison, when we're treating infants who have already developed symptoms, we see increases, we see stabilization, we see slowing of disease progression, but they may never achieve the sort of milestones that we see when we're treating pre-symptomatic infants. Next slide. This slide shares with you the pre-symptomatic clinical trial outcomes using Zolgensma, the gene replacement therapy. And in looking at this group, when we look at the 2-copy babies who received Zolgensma pre-symptomatically, half achieved age-appropriate gross motor milestones, and all achieved age-appropriate fine motor milestones. When we looked at the 3-copy babies, all achieved age-appropriate gross motor milestones, and 14 of 15 achieved age-appropriate fine motor performance. In the clinical trials for Zolgensma, there was not, it was an open label trial. There was not a control group. We used natural history data that was available, and also information that was based off the nusinersen trials. Next slide. So this is a slide just showing you some of the characteristics of the 3 treatments that are approved for SMA. As a longtime clinician, I am just blown away every day when I think about how far we have come versus where we were prior to 2016. So we're at a phenomenal place for this disorder. For newborns, there are 2 treatment options, Spinraza and Zolgensma. Evrysdi is approved for infants over 2 months of age. And I'll just let you look through those characteristics. There are a variety of reasons why infant may go on one treatment over another. Part of our long-term follow-up goals is to better understand this disease and how these treatments impact the disorder. Next slide. So in response to the rapid change of spinal muscular atrophy, it's so critically important to gather data about SMA population. And I know I am totally preaching to the choir here. And HRSA is committed to gathering real world data. And we have 3 pathways right now to collect data. I'm going to talk to you about more about 2 out of the 3 with subsequent slides. The SMA Newborn Screening Registry is a registry available to families. Families can go in to our website for the registry, provide consent, and then answer survey questions about their child, including when was the child receive their confirmatory diagnosis, when did they start treatment, what treatments, did they have any symptoms at the time of treatment. And this is designed as a longitudinal registry so that families will be invited back to answer additional questions every year. The second pathway is our HRSA membership database. And this is information that families provide to us when they call and they talk to us. We collect some information about patients. We also send out an annual survey or make available an annual survey that's open for about 6 weeks, where families are, patients and families, caregivers are invited to answer questions about their experience with SMA. We also use this database to recruit for clinical trials and surveys, and also gather that information to better understand the experience of SMA over time, and we share that with payers, regulatory officials. We really try to use it to advance care and opportunities for the SMA community. The third registry is our clinical data registry, and this is a registry that we started approximately 3 years ago. We have an SMA Care Center network that is growing. We currently have 19 centers that are affiliated with our Care Center network for SMA. And those centers can send patients and clinically collect, so information that they document within the electronic medical record is sent over to our clinical data registry. I know Dr. Brosco, you talked about the EHR and the challenges because we don't have a universal EHR or EMR, and we totally agree with you, but we're really trying to understand and maximize moving data from the electronic medical record, where in my opinion as a clinician, that's where patient data belongs, and move it over to our registry in a reasonable way that we can analyze and mine that data. Next slide. This is some information about from our membership database. So this is patient provided information, and the first graphic is just new contacts diagnosed via newborn screening. So this isn't all of our new contacts, but it's just specific to the newborn screening over time. So it's divided by months and years, and we've seen a gradual increase in the newborn screening babies who've contacted us, which we expect as part of just the growth in states that are implementing. But one of the things I just wanted to point out to folks is that what we, during the early months of COVID, we had fewer infants diagnosed both clinically and through newborn screening. We saw a lull in those diagnoses and patients coming to us. So we also saw in our data that reflection, what we interpreted as being just decreased in-person visits and evaluations of infants under the age of 2. So our perception is that there may be a delayed diagnosis for infants with SMA who have clinical symptoms. On the right is the breakdown of SMN2 copy number. And approximately 50% have 2 copies, with a small percent having 1 copy, 32% with 3 copies, and 17% with 4 copies. And then some, and it's just know that when positive newborn screens are sent to commercial labs for confirmatory testing, typically the highest number of SMN2 copy number is 4 or more. Some labs Baker, as a shout out to Wisconsin, is able to distinguish between 4 and 5, but most of the commercial labs are not. So we have this grouping of greater than 4. Next slide. So again, so we have the HRSA newborn screening portal survey. So this is we invite families whose child was identified with SMA through newborn screening, and the parent provides consent they can complete the survey, or they can abdicate the responsibility to have their healthcare provider complete the survey. And that is the link to that. And we receive support through our HRSA Newborn Screening Coalition, which is HRSA, Novartis, and Genentech. Next slide. Some of the data that we've collected thus far with 25 infants, what we have are 10% have one copy of these 29 infants, and we appreciate that this is a very small number of infants. 2 copies, we have 42% of the infants have 2 copies, 31% have 3 copies, and 70% have 4 or more. And then we also provided you with information about treatment status. So the majority of the infants received treatment. Now, there is a caveat that some infants were, some families completed the survey prior to being able to receive treatment, but I would say that 90% were past that window. So there are some families who declined treatment for their infant. Next slide. This slide shows you information about age at diagnosis, divided by copy number, and also age at treatment. So not time to treatment, but age, how old was the child at the time they received the first treatment, regardless of what the treatment was. And the range for age of diagnosis was 0 to 22 days, with a mean of 6, and a median of, I'm sorry, it was a median of 6. And you can, and again, these are small numbers. And then for age of treatment, the greatest spread was at 4 or more copies, where we had a child who was 1.5 years before they received treatment. So we're continuing to collect this data. We really, we want to understand better the processes that go on. Just know that in comparison, symptomatic infants, typically from the time of symptom onset until they were diagnosed, for 2-copy babies is months, typically 3 months. So newborn screening is just so dramatically changing this experience, as well as this disease. Next slide. So our future plans are to evaluate the SMA newborn screening outcomes across the real world evidence data sources, all of our data sources that we're collecting. Things that we're very interested in is time to diagnosis, and how can we improve that. And I think that goes back to looking at the clinical care delivery, and what happens when the referral happens to a referral center, time to treatment, symptom spectrum, which we know is changing, and then also understanding SMA phenotype. We historically have talked about SMA as by types, and that is transitioning to talking about infants regarding their SMN2 copy number and maximum motor function achieved, because many of these children being treated pre-symptomatically cannot be defined as a type in any sort of fair way. So we've actually added a category called unspecified when we're talking to our clinicians, because our older, our teens and adolescents pre-treatment group have an identity as an SMA type, but our new infants who are getting treated pre-symptomatically are being thought of in a different way. And our community is in a transition in how we think about SMA as a disease. Next slide. Thank you so much for allowing me to share with you our experience and our hopes and to some extent our dreams. And thank you all for the work that you're doing. And I greatly appreciate the presentations that I've heard today. Thank you.
Thank you very much for sharing this information, and to Cure SMA for collecting all of this data. Next, we're going to hear from Dr. Amy Brower.
Mia, are you advanced? Gotcha. Hi, everybody. Thank you for the opportunity to contribute to this important panel and present an overview of MDS-TRN efforts to facilitate the collection, analysis, and sharing of longitudinal data. I'll begin today with a brief overview of the MBSTRN, followed by a description of our experiences supporting long-term follow-up efforts and highlight new tools and resources. Next slide. The Eunice Kennedy Shriver National Institute of Child Health and Human Development's Hunter Kelly Newborn Screening Research Program was created to support investigations and innovations in newborn screening. Recent efforts have explored the use of genomics in the neonatal period, conducted prospective pilots of conditions that are candidates for nationwide screening to evaluate clinical benefit, and the development of novel screening technologies for candidate conditions. Next slide. The American College of Medical Genetics and Genomics plays a key role in these groundbreaking efforts by leading the NICHD's funded MBSTRN, or Newborn Screening Translational Research Network, which is a key component of the Hunter Kelly Newborn Screening Research Program. We began our efforts in 2008 as an effort to engage a variety of stakeholders across the newborn screening system. MBSTRN has now matured into a dynamic and committed network comprised of researchers, healthcare professionals, state newborn screening programs, families, and advocacy groups. The MBSTRN team at ACMG is beginning its 13th year with a renewed mission to facilitate the discovery and validation of novel technologies to screen and diagnose disease, pilot new technologies and treatments, describe the ethical, legal, and social implications of newborn screening research, and collect longitudinal health and genomic data. Next slide. Newborn screening in the United States is a multi-component, multi-stakeholder system of prenatal education, hospital and state-based public health laboratory screening, clinician and state-based laboratory confirmation and diagnosis, clinical treatment and management, and health outcome analysis. The MBSTRN data tools, resources, and expertise are designed to facilitate the efforts of all stakeholders and leverages each component of the newborn screening system to advance research. A steering committee and 6 expert work groups guide our efforts, and we welcome your involvement. Next slide. The neonatal screening of 4 million newborns each year in the United States leads to the diagnosis of over 20,000 infants with a genetic condition that requires referral to clinical care, and in most cases, lifelong management. This unselected cohort of newborns reflects the racial, geographic, economic, and education diversity of our nation. This may in fact be the perfect cohort to help advance disease understanding, because although every newborn receives essentially the same screen, other factors vary, including treatment choice and the course of disease. In addition, many of the screen conditions have comorbidities, including intellectual disabilities, and these children could receive a variety of interventions that could be tracked and analyzed to identify critical periods of development and intervention. Because the newborn screening system in the United States so successfully and effectively screens over 99% of newborns, it has the potential to provide a unique platform for understanding rare disease and lifelong outcomes. In fact, the process of neonatal screening, followed by a coordinated transition to clinical care, facilitates the collection of health information beginning just hours after birth. And because the majority of newborn screen conditions require lifelong care and management, we have the opportunity to conduct prospective, longitudinal natural history studies on a population basis with unbiased ascertainment. Over the last decade, MBSTRN has been involved in developing a data tool to support several landmark natural history studies and pilots that have contributed to a better understanding of the etiology, pathophysiology, and phenotypic heterogeneity of newborn screen conditions, and began to provide an assessment of health outcomes for these conditions. Next slide. We developed the longitudinal pediatric data resource to establish a common data model and provide a secure environment for researchers to collect, aggregate, analyze, and share phenotypic and genomic data in question and answer sets, or commonly called common data elements, that were developed by subject matter experts. The committee's publications and follow-up and treatment subcommittee have guided these efforts, including a focus on the key components of long-term follow-up and the Hinton framework. The collection and analysis of long-term follow-up data from newborns diagnosed with a condition through newborn screening is important to ensure that we achieve the best possible health outcomes for these infants, and the LPDR enables parents, health professionals, researchers, public health teams, and advocacy groups to advance knowledge and contribute to this important goal. Since its launch in 2013, the LPDR has been utilized by several research teams and state newborn screening programs conducting longitudinal data collection of both RUSP and candidate conditions, efforts that explored the use of genomic sequencing in the newborn period, and groups that were conducting pilots of candidate conditions. Next slide. The LPDR is housed within a FSMA moderate cloud environment and is available for use by all MBSTRN stakeholders. Key objectives of the LPDR are the sharing of findings and secondary use of accumulated data. The LPDR facilitates this data sharing and data standardization with third-party databases, including the NIH's National Center for Biotechnology Information, or NCBI, database of genotypes and phenotypes known as dbGaP, and the National Library of Medicine's NIH Code Repository. The LPDR also provides access to data dictionaries from studies that can be used to create electronic data entry forms, and also features case-level data sets that are de-identified and available for data mining. The secondary use of accrued LPDR data may help to establish the efficacy of new treatments and management approaches, inform the community about the value of early identification and treatment through newborn screening, and identify areas for improvement in disease management throughout the lifespan. Next slide. From coast to coast, over 100 researchers, newborn screening state programs, and advocacy groups have used the LPDR in over 30 basic, translational, public health, and clinical research projects. The LPDR is designed to share these teams' new findings and foster the secondary use of these original data sets. Our newly launched website enables investigators to explore unique data sets, collaborate with leading investigators, and design studies using validated common data elements. In newborn screening, the use and development of common data elements is focused on facilitating data collection, sharing, aggregation, analysis, and dissemination. The ability to combine data sets is especially important in newborn screening because the majority of conditions are rare, and accumulating enough subjects to have statistical power is often a barrier to understanding health outcomes and the benefits of early identification and treatment. The MBSTRN website has data displays that describe the types of data and populations that are available for secondary use, and our data governance and data sharing policies provide qualified users access to these data sets. Next slide. The LPDR has been utilized in a variety of efforts, including a 10-year effort to collect, analyze, and disseminate health information on individuals with one of 42 different RUSP conditions, collected in 30 clinical sites located in 22 states. It's also been used in multi-state pilots of 4 conditions that collectively screened over 1.2 million births. The LPDR has been used in genomic sequencing of 4 cohorts of newborns, including infants in a neonatal intensive care unit, and also was used in studies that are beginning to expand the diagnostic window of newborn screening both beyond and before the neonatal period. The LPDR also has been used recently by patient registries. So we're helping groups and advocacy groups that have developed patient registries to consolidate them into a single data dictionary that will support future expansions of the newborn screening panels. To develop the CDE sets, we recruited subject matter experts who care for newborn screen identified individuals. These subject matter experts make up our clinical integration group, which includes mostly clinicians and plays a key role in defining the type of information that would be useful to collect. As the data sets contained in the LPDR grow, we hope that healthcare teams can utilize this information to inform their clinical decisions. The NBSTRN Clinical Integration Group has generated CDE sets containing over 24,000 data elements across 75 conditions. The CDEs have been used to develop electronic case report forms and have been utilized in a variety of research projects, resulting in case level data for over 8,000 subjects with an average of 4 data collection time points per subject. Next slide. As the data accumulates, it becomes more useful. An example of this is our recent work with the Inborn Errors of Metabolism Consortium. The initial IBMC effort enrolled over 2,000 subjects across 42 RUSP conditions, utilized an average of 7,000 CDEs per condition, and collected longitudinal follow-up or data collection. These LPDR data sets contain a lot of questions, but importantly, they contain what expert clinicians thought were disease-specific questions to ask longitudinally. So we think it's sort of a starter set for what could be asked longitudinally. Next slide. So the IBMC effort informed a related effort with the National Coordinating Center for the Regional Genetics Networks, which work with state newborn screening programs and public health departments to think about, instead of asking many questions to really learn more about diseases and outcomes, what could we empower state programs to do? So we met in 2013 and brought together many clinical experts and state programs and looked through these many question and answer sets. And we actually came up with a consensus set of 4 minimum questions that could be used by newborn screening programs to conduct long-term follow-up data collection. Next slide. The NBSTRN recently launched a new website designed to expand our tools and resources. This improved website furthers the NBSTRN's mission to foster collaboration among newborn screening stakeholders and facilitate research. In addition to the case level data sets and expanded CDE sets in the LPDR, 2 new tools were developed that provide key information and statistics and foster collaboration across stakeholder groups. Next slide. Currently, newborns in the United States are screened for 81 disorders, 61 RUSP conditions, and including 61 RUSP conditions. In addition to the screen conditions, there are thousands of rare disorders that may be candidates for newborn screening. This tool, the Newborn Screening Conditions Resource, provides a centralized resource of facts and statistics on both screened and candidate conditions. This tool is designed to be an interactive resource for researchers, clinicians, parents, families, and advocacy groups to learn more about these disorders. And it provides links to the National Library of Medicine and NCBI resources. NCBI, importantly, provides access to biomedical and genomic information and maintains MedGen, NCBI's portal to information about human disorders and phenotypes that have a genetic component. Using a filter module within this tool, you can sort conditions by nomination and ACHDNC category. Next slide. Because newborn screening programs play a critical role in expanding the number of screen conditions by participating in research and research pilots, and by providing access to residual samples and data, the NBSTRN created a new tool called the NBS Virtual Repository of State Subjects and Samples. This MBS VR provides national and state level views of policies and procedures of interest to researchers, clinicians, families, and advocacy groups. The MBS VR gives users insight into the number of conditions screened in each state or territory, the number of expected cases, and the incidence rates of conditions that are currently part of nationwide screening or conditions that are candidates for pilots. This tool also details the number of births per year and the distribution of race and ethnicity by state. 80% of newborn screening programs retain samples longer than 1 year, and the MBS VR helps researchers request these samples for their studies. 23 newborn screening programs screen for conditions that are not currently part of the recommended uniform panel, and this tool enables providers, families, and advocates with a link to additional information on these conditions. In addition, this tool provides easy to navigate visual summaries of key statistics and enables clinicians to connect with their local newborn screening program. Next slide. The MBS-TRN team has worked with the National Library of Medicine, who is creating a repository of CDEs to facilitate data sharing. The NICHD CDE repository currently catalogs over 26,000 elements across 16 classifications, with multiple NIH institutes and efforts being represented. The MBS-TRN work is represented within the NICHD module. This repository is designed to allow researchers to build data collection instruments from shared CDEs and also to contribute generated data elements. To foster the use of these standardized CDEs, MBS-TRN deposited question and answer sets within the NICHD module, and these are now available for use by the research community. Next slide. The ACMG team is committed to enhancing the MBS-TRN data tools and resources to support the multiple stakeholder groups and environments within newborn screening and to help accelerate discoveries. We look forward to working with the committee on future initiatives and are happy to provide any additional information that would be helpful. Next slide. Thank you to the NICHD for funding, supporting, and guiding the development, maintenance, and enhancement of the MBS-TRN. Thank you, everybody.
Thank you, Dr. Brower. And thank you to all of our panelists for your excellent presentations today. Now I'd like to open it up for questions or comments from our committee members, followed by organizational representatives. Scott Schoen.
Dr. Powell. So Jeff, I have a quick question about, so thank you everybody. Let me start with that. Jeff, I have a quick question about your comment on equity. It really jumped out at me, and maybe it's for Anna Marie, because I want to make sure I got it, I understand it, because my comment will depend on if I followed it right. And it seemed as though there was a suggestion that we can't solve all the equity issues, so we should just move ahead with whatever it is, in this case, a newborn screening disorder, and that equity should or does follow. Can you just clarify that for me, make sure I got that right before I?
So let me say a couple, is it okay if I speak, Cynthia?
Yes, please go ahead.
Jeff Roscoe, committee member, sorry about that. So let me try to say it more clearly, and then maybe Anna Marie can jump in. You can imagine sort of two extremes. One is, yes, we have newborn screening, but the treatment is either so expensive or so rare or so impossible to find that why bother for newborn screening, because the treatment's there, but nobody can get it. And at the other extreme, it might be that, yes, we have a perfect system that works great, and every single child who's identified immediately is available for treatment, follow-up, clinical, and otherwise. So the question really is somewhere in the middle, what happens? So if we said, yeah, 80% of kids who get identified can get treatment, we'd probably be comfortable with that. But as it starts moving further and further away, it's harder. And I'm remembering specific conversations, less at the national level and more at the state level, where families would basically say, and advocates and clinicians, yes, I know we can't get this to everyone in the state right away. There aren't enough clinicians, insurance isn't paying for it, whatever the issues may be, but we can help these children right away. So why wait? So that's sort of one argument. The argument from equity is, well, that's simply not fair. And we need to make sure that if we're going to do a public health program where we identify, in theory, every infant who has a condition, we have some responsibility, either as a state or as a society, to get treatment in place. And I think, and Anna-Marie can speak for herself, but she made a really eloquent argument for that first side, which is if we can help 40 or 50 or 60% of kids, we should do that right away. And that can spur reaching out to the kids who aren't reached right away. Maybe she should say what she's saying better than I can.
Anna-Marie Saarinen.
Thank you, Anna-Marie Saarinen, committee member. I don't know that I can say it better than that, but I'll try. What I was trying to get at, well, there's two different pieces. One is sort of how these numbers and the information we know today impacts how we're evaluating and moving things through the nomination and evidence review process. So it's hard for me to separate the two, because for that one, I think all of these considerations come up, you know, for me as someone who's trying to look at all the evidence in the data, because I think I've mentioned before, I'm sort of an advocate for thinking about how provisional acceptance of conditions on the front end, right? Just even at the early, from moving from nomination eval into evidence review, that is a pathway we can and should be considering, because sometimes that is the only way to get us from point A to point B. This is without provisional acceptance or provisional addition, that patient population will struggle to meet all the criteria or to come up with the evidence required to check mark that box. So I'm just gonna say that on the front end of things. But what I was trying to get at on the other side was that the suggestion that we should wait to add something that has ticks off all of the baseline evidentiary requirements, because we know we might have an access to treatment issue or what we would call a gold star equity mark, to me feels substantively wrong. Because then if you just from an ethics standpoint, you would be talking about denying access to those who can, in the present paradigm, get access, right? So we're saying, so if there's 50% of kids, we'll say like, yeah, but you shouldn't be able to get an early diagnosis and access to care because we have 50% that are going to be challenged to get that now. And so how does that play out from an ethics standpoint, right? So my experience in newborn screening for congenital heart disease, particularly in resource poor settings now, and I hope I can just bring that in as an example, is that the data is the evidence that's often required, and it can drive the advocates and the policymakers to make the improvements that are required. But if we don't sort of move forward based on what we have, again, like letting the perfect be the enemy of good, I think that's a real challenge that we have. We're basically denying the opportunity for a better outcome or survival for a subset because we haven't reached that perfection on the equity side yet. And I really have seen this happen in practice in very resource challenged settings, where once you provide public health the information on startup programs, that they start getting the data, that they actually will make investments in treatment infrastructure. And I mean, the optimist in me says that actually works, and that can continue to happen even in some place like the United States that has more. While I have the mic, I'll just be really quick to thank Amy Brower. That was an excellent presentation, and it really reminded me how important the NBS-TRN is to the work of this committee. And I almost feel like we should have, again, this is a suggestion, take it for what it's worth, but I almost feel like we should have a placeholder in every meeting to do a micro report from NBS-TRN, because the data you provide is so useful, and it can trigger so many actionable things, not just for the primary committee, but for the work groups. So I want to thank you for that, Amy, and thanks for all the good work.
Yeah, thank you. We'd be happy to do that.
May Baker?
Hi, my question is for Dr. Schultz. So you mentioned that you have 3 pathways to collect the data for the registration. I just wondering, did you think sometimes there could be overlap? I mean, do you have a structure in place? Be sure that the children were not counting twice?
Yes. So the newborn screening registry overlaps with the clinical data registry. So the newborn screening registry is patient-reported outcomes, but it does overlap with the clinician-entered data. Separately, we have our membership database. When we are able to cross-match all of our databases together because they're all owned by HRSA. So yes, when we do reporting, and we're starting those analyses now, looking at what data we have across our registries. But our intent with our registries is to not double count patients. So within our registry, we have within the clinical data registry, we have PHI, and then we have PII in our membership database as well as in the registry. So we have that ability. But our plan is not share that personal identifying information externally.
Yeah, thank you. I thought you would. Just want to confirm.
Thank you, it may.
Scott Schoen, did you have another question?
Thanks, Dr. Powell. Yeah, thanks to Jeff and Anna Marie for clarifying. So I guess I'm more of a comment than a question, which is that I think that the comment of letting the perfect be the enemy of the good assumes we have good. I think we still have, reflecting on the disorders that we have and I just feel that in our healthcare public health system, we achieve something and we move on. Like we're already looking to the next disorders and the next disorders. So I think it is more informative that we have to look back at what we've done and add the equity piece to that assessment, right? So, and we talked about it, but I think Jeff's comment in the preamble to here requires that because the same groups continually get left behind, whether it's newborn screening or any other public health problem that we are seeing and is so exacerbated by this pandemic. So again, not that newborn screening saves all, but we have an obligation to look at this in what we've already done, that we still have immunology deserts dealing with SCID 10, 12, 15 years out. We have treatments that are more costly and more costly. We're creating the gap between equity and fairness and good and perfect even broader. So we absolutely have to bear this in mind. That's my comment, is that we can, and I'm not suggesting we're not, but I don't necessarily agree with if we build it, equity will come.
So I know there's an order here, so I'll just reply to that, since I wanted to ask Scott, but I couldn't find the chat place to say, did I semi-answer the question? So I 100% agree with you on the evaluative piece, 100%. And this is where, I mean, not to sort of connect or weave a thread that might sew everything together, but this is where, like, the stuff that MBS-TRN is doing, I do think provides such a valuable platform to do that sort of analysis. And I don't know that we have as much, well, or all of us anyway, have as much visibility into that we maybe should or might like to. But if that's exactly what I was saying. I think my fear is that I do believe in my Pollyannish way that if you build it, they will come to a degree, but you can't just build it, have them come, and then not ask them how their experience was when they leave the ballpark. So it truly, you have to go back and look, and you have to use that data to either improve the program, to make those necessary adjustments, or say, like, holy crap, this didn't work like we thought it was gonna. And I think that's very fair. So I want to agree with you on at least 75% of what you're saying.
Thank you. Robert Ostrander, I'd seen your hand raised earlier, but I don't see it now. Did you have a comment?
I really did not. I mean, I had a little minor one, but I think I just bumped my hand up anyway. So I appreciate you recognizing me, but for once I'll keep my mouth shut.
No, we appreciate your comments. Natasha Bunham.
Great, thank you. I have a couple of comments and I think a couple of questions, but Scott really covered a lot of what I was really itching to say. We can't start to have a conversation, a true conversation around health equity until we really acknowledge that when we say, oh, there's the 20% or the 50%, it's always the exact same kids and it's the exact same families. And if we can't acknowledge that, to me, it feels like a very much a thought experiment as opposed to what is happening with real families. So I appreciate Scott for saying that. I also really wanted to acknowledge the data that was presented from SMA. I was really excited to see that data because I feel like, oh, we really are seeing data from the full system, especially the part of the system that oftentimes is left to support the families. And to be able to have that data was really refreshing. And I really applaud you to have that infrastructure to capture that data because it is a lot, especially to put on the patient advocacy organization. So really great work happening there. So thank you for sharing that. And I hope that we can see something similar for many of the other conditions that we tend to talk about. And now to my questions. It was great to get this update from LDPR and, the visuals are beautiful and it's really great to see how these different pieces are being connected. I guess one question I have in the realm of this conversation about health disparities and what we're learning, do we feel like now with these amazing tools, both through NBSTRN and other places, that we are closer to being able to answer some of the questions that we've been asking for quite some time around are our outcomes better? Are there disparities? Where are the disparities? How are we addressing them? I think because the exciting part about building tools is being able to implement them and to be able to say, gosh, 10 years ago, we couldn't answer this and now we can. So just wanting a bit on that. And then lastly, my last question, I guess it's directed to Carol around the great work around long-term follow-up and really thinking about that. Could you speak a bit more to kind of, and I apologize when those slides were going through, I was not able to look at them, kind of like that connection around the work that has been happening and will be happening through this work group around long-term follow-up. And is that like really focused from the lens of the public health programs? Is it from a lens of, long-term follow-up, from a systems perspective? If you could just highlight that, that would be great. And I think that's everything for now. Thank you.
Thanks. Amy Brower, do you want to respond to Natasha's first question? Amy,
sure. Sorry about that. Yeah, so I think, Natasha, what you point out is that the more data we have, the more useful it is. And that's what we've seen over the years. But as we've presented, this is such a unique opportunity in newborn screening. Every newborn gets screened, but we can't follow every newborn. What we've learned over the last several years is, we are project by project, disease by disease. We've got such an amazing range of ages. So we have from newborns all the way up to 80-year-olds. So as the data accumulates, it's really becoming useful, but are we getting everybody? No, we're not. And can we start to answer some questions? Sure, we can, but again, it's disease by disease. I would love to be able to follow, every condition in the way that we follow now sickle cell, SMA, we've got projects where we're helping states conduct annual check-ins, and I think that's a good step. So I think we're getting there and we're making steps, but I don't think we're anywhere near addressing some of the issues that the committee has brought up.
I guess just to add to that, I can definitely appreciate that. And I do think more data is helpful, but I think what's also really helpful is really understanding how we're asking certain questions. And I think that's something we're all learning, especially from the lens of health equity, is, it's having the data, but also asking the question and then being like, oh, I guess I asked this question, but I actually meant this question, and really building upon it that way. So I think really having a focus on both would be great. But thank you for your response.
And Carol Johnson, do you want to respond?
Yes, thank you, Dr. Powell. So Natasha, early in the presentation, I talked about how there was a lot of discussion, and we ended up having to focus on 2 separate projects. I think our list was extremely long and encompassed both what's what's in front of us, what do we need to work on today, as well as the system, as you mentioned. That said, we would love to hear from you. Any ideas or recommendations that you would have would be very much helpful. I do think, we have some ideas for what we need to work on in the future, but maybe those aren't what we should focus on right now. Maybe there are some other ideas that you might have, and again, members of this committee might have for us as to what to do next. Did that answer your question, Natasha?
Yeah, and I think that it's important to kind of think about, these questions from all the different viewpoints. I think has been said. I don't know, I think it's
absolutely
50 times today. Newborn screening is a system with lots of different parts. So
right.
I think that's great and so exciting to see.
And that's why it was so overwhelming in the beginning to try to decide what to focus on, right? So yes, thank you.
Jed Miller.
Yes, hi, Jed Miller, Association of Maternal and Child Health Programs. I have a question for Carol Johnson regarding the landscape survey. One of your slides presented about 8 respondents who track the number of individuals lost to follow-up.
Correct.
And I'm just curious, were any comments, and this is, I guess, a question for you or anybody else here, on the panel, is did anybody volunteer any information about dedicated programs or efforts to try to find those lost to follow-up, to number one, discern if they're truly lost or just administratively lost? For instance, if somebody moves out of state or out of the country, change providers, or just something in there's a disconnect, but they actually aren't lost, versus others who truly are lost and who really need help. And there's a lot of factors that go into that. Just kind of curious if any knowledge was shared with you or if anybody else. Thanks.
Is it okay to go ahead and
Oh,
comment,
yes,
Dr.
go
Powell?
ahead.
Okay,
Sorry.
just wanted to make sure.
Yeah.
So I don't know that we had that level of granularity in this survey. Different programs do different things to track their loss to follow-up. Some programs have a very active and robust way that they track those. I can speak only for my program right now, but we do a weekly review of birth certificates versus newborn screens, and we absolutely do active follow-up to try to get those babies in to be screened. And we believe we're at about a 99.6% rate of at least being able to determine what happened with that baby. And that includes, the refusals that we receive as well. It does vary program by program, and this is my shameless plug for the new CLSI follow-up guidelines that are going to be adopted in the near future, and working towards some minimal standards in follow-up. And that is one of them, and it's important, and that is why it's one of our quality indicators.
Thank you very much.
You're welcome.
Thank you. Chris Cuss.
Yes, a general question, and it's at the end, and I know, but I'd be interested in the panelists' comments about a general question about have we made progress regarding newborn screening long-term follow-up over the past 5 to 10 years? And what do we need to do to make progress?
Anyone want to take that on? Dr. Brosco, I'll pick on you.
No, that's totally not fair because Chris and I were talking about this. It was a great question. So I said, you should go ahead and ask it. I'd like to hear actually from Carol Johnson, and maybe Carol, you might mention in particular where, you know, a little bit about what you've already reported on, but also how new steps might fit into this. You know, is there a way to extend or what kinds of things APHL could do? One of the things that really impressed me was a number of states seem to say we need standards. We need a mandate.
Correct.
You need to tell us what we need to do.
Correct. I absolutely believe that to be true. And I speak on my own behalf, that people are looking for guidance. They're looking for help. They want to know. Newborn screening programs really want to do the right thing, but sometimes they have so many barriers, as you saw in those slides, that they can become insurmountable. Right. So I think, yes, minimum standards, guidelines, what are the elements of a long-term follow-up program? And you could ask, you know, the 54 states and territories and perhaps get 35 different answers, right? So again, that comes back to, we do need to set some standards. And then from there, we have to be able to convince the powers that be that long-term follow-up is actually not an add-on component of newborn screening, but an essential component of newborn screening.
And I guess, and I'll jump in and say, you know, I think some of the things are true. If you build it, they will come. So, you know, luckily we've been funded to build some tools and infrastructure, and we've seen state programs come to us. We're working with several right now, you know, who are particularly interested in subsets of the RUSP, or, you know, and that's the great thing about newborn screening as a geneticist is there's so many diseases, but that's the tough part. There's so many diseases. And so trying to build a system where you can really understand more about the diseases. You know, we're learning so much about SCID, about sickle cell, about every single condition on the RUSP as we collect this data. And it's such a missed opportunity that we don't have a national system to follow these children, yes, whether it's letting parents, you know, enroll, letting states follow them, encouraging clinicians to follow them. You know, there's just so many ways that we could do this, I think.
Right. And I'll make another comment, and that is that we have some programs that are really struggling just to call out abnormal results, right? And so I don't know what comes first, and this goes back to this overarching theme for today's talks, is that if you build it, will they come? We also have to fix some things that we're already doing, right? And that is to appropriately staff and fund follow-up activities, whether that's in the short-term follow-up or long-term follow-up.
Deborah Friedenberg.
Hi, I was just going to add a little bit more to Jed's question to Carol as one of those participating programs. And Carol's quite right. Each program does choose what they want to do, but I know that, like for instance, before a child is placed in the long-term follow-up category, lost to follow-up category, there's a great deal of effort that is expended into finding that child, finding out what happened to them. Did they switch states? Did they go to another provider? Was there a loss of just contact? And there is a great deal. Now, I can't say that happens for every program, and then there's a review of those children that are going to be put in that category before they're actually put into that category. So there really is, you know, from the state that I'm involved with, a great deal of effort that's expended, before a child would be put into that category, and they're only put into that category very reluctantly. That it's not viewed as a positive to have to put a child into that category.
Melissa Parisi?
Can you hear me?
Yes.
Okay, thanks. I just wanted to make a quick follow-up comment to this recent discussion, and in particular, Amy Brower's comment. I mean, you know, from a research perspective, I think we all would agree that every child identified with a newborn screening condition in the best of all possible worlds would be automatically enrolled in a long-term follow-up research program where we would track and acquire the information that we need to really understand the natural history of these conditions. I mean, given that they are rare disorders, you know, we're just scratching the surface when we nominate and vote to add a condition to the RUSP. So, you know, to the extent that some of these systems can be put into place, such as through the you know, APHL New Steps or the NBS TRN, to allow for the accumulation of data in a de-identified manner, even in a way that can help inform our understanding of these disorders, that in my mind would be win-win and help us get towards this path of creating true equity for these conditions and these kids who are affected.
Thank you. Robert Ostrander.
So now I do have a quick comment, and this came from our discussions in our work group a couple of years ago when Joe and I had talked about this federated system. And I think one of the potential resources that we're overlooking is the specialty centers for a number of these conditions. I mean, that is a nationwide network to some extent, because I think these specialty centers communicate with each other pretty regularly, if nothing else, at national meetings and reading each other's papers and literature. And it seems to me that we should tap into that as the basis of a federated system. And you know, to the comment that you know, Jeff carried forward from our group, whose responsibility is this? I think we should think about ways to make that part of the responsibility of specialty centers, is collecting a data set on these various conditions that you know, are under their various purviews. Thinking about that Venn diagram, you know, there are probably some universal questions that apply to every kid. There are some questions that apply to kids with special healthcare needs. There are questions that apply to all kids diagnosed through newborn screening, and there'll be disease-specific questions. And again, if we could somehow suggest that this is the responsibility of specialty centers, and then have some sort of national clearinghouse that would collect that data, and maybe even design the, you know, what are we looking for questions. I really think we should strongly think about that. And again, I don't know what the purview of this advisory committee is in terms of advising the secretary to perhaps set up a clearinghouse. But you know, we've heard of a lot of people that are potentially providing data, but I think the specialty centers is just the right size and shape as a potential data source for a lot of these things.
Well, if I can comment as someone from one of the specialty centers, while I think that's a great idea and a great way to do it, similar to the public health labs, we're stretched so thin. You know, we can't, you know, hire new people to enter that data. We just don't have the funding. So it's all coming down to how do we fund this, both at the laboratory as well as the clinic levels.
No, and I certainly agree, and that's where I wonder where your you know, how far the advisory committee can go in terms of suggesting that. I mean, suggesting that it be done is one thing, but when you suggest something be done, it's best to suggest a how. And obviously, money's an issue. But you know, the specialty centers around here, the pediatric departments for the NICU graduates do a wonderful job of gathering data on all their NICU graduates longitudinally through their lifetime up until 18. And you know, that's the kind of model that made me and Joe think about this, is what the NICUs do.
I know, and I think, you know, there's similar things that they do for pediatric cancer and follow-up of those cases. And that's one reason, you know, they've made such great advances in treatment. So I think we really need to start looking outside the box, so to speak, you know, to figure out ways how others have funded this and how we might go about suggesting how this be funded. I know we're running short of time. let's see, Jennifer Kwan, you haven't had a chance to speak. Go ahead.
Thanks. I actually just lowered my hand because a lot of what I wanted to say, but I will respond to Chris's provocative question with a provocative answer. I don't know that we've made great progress in long-term follow-up for all of the reasons that we've heard. I think we've made incredible progress in making treatment advances available to children with rare disorders. I think that that's been sort of the core job of this committee, and you've done a great job. I think that the long-term follow-up is such a key piece, as we all know, and I think that people are just scrambling about how to address that need. So I recognize that. I wish I had some ideas, but just that comment.
Thank you. Anna Marie.
Hi, thank you, Anna Marie Saarinen again. I've been really listening to everyone's comments, and they're all just very valuable and spot on. But I was trying to think of it as like we're asking a question, and is there a model, and sort of like the way recovering lobbyists sort of think about things. And I did pull up, and I'm sure it's on the website, the letter both from Chairman Howell to Secretary Sebelius back in 2010, and then the reply letter back from Secretary Sebelius. There was more than one, as you might recall, for CCHD screening. But what I loved about that letter from the Secretary back to this committee was that it came with an action plan. It didn't come with necessarily dollars connected to the action plan, and I think that may be the missing link here. But it basically said, like, the following things need to happen as we implement a new condition onto the panel here. And they fell into the buckets of research, surveillance, screening standards and infrastructure, and education and training. And under each, it basically said, HRSA shall do this, CMS shall do this, FDA shall do this, NIH shall do this. And some of them were kind of time bound. But, and so as I look at them, I can see which ones we could say like, yep, that actually happened. But I see ones that I don't know, I feel like I can say like, that didn't happen, or that hasn't happened in a way that was useful in coming back to this committee to say, upon implementation of this screening, as it rolled out, what pieces are still missing that may impact access, equity, and outcomes for children affected by that disease. But I do think there are some models out there. I would even consider looking at this, reauthorization of the Newborn Screening Saves Lives Act. What can be embedded at the policy level to ensure that the fiscal and human burden of doing the things that need to be done when these conditions get added doesn't fall on programs that are currently underfunded and understaffed to be able to do it. And I think at the end of the day, it all comes down to money. And if you don't fund, and that's why I use the word infrastructure, that's what it is. It's about money and funding. So I guess I would encourage us to look at some of these things that are already embedded in the way HHS has thought about newborn screening, and how, at least for CCHD, that came back with like a set of deliverables that were supposed to address some of these issues.
Thank you. So we're running out of time. May Baker, Melissa Priestley, and Jed Miller, and then we'll need to stop.
Okay. I just want to make a very quick comments. For the long-term follow-up, but I heard so many good ideas, the things, and I think I want to echo Melissa was saying, like, ideally, actually, I think we should make the goal. Not just like ideally we will start with newborn screening at that. I think we need to set the kind of goal to do that. Otherwise, we will never get to the point we need to be. And the one thing that I just want to emphasize when I hear this, it's the connections. Because I think, we heard Amy have the wonderful presentations. I think they've done amazing job to reach out all this, specialties, clinician stuff that, and coming back a newborn screening program, and I can tell my personal experience after short-term follow-up, continuing to have the connection with the clinic, kind of somewhat a little bit, I just I don't know what words put in because the incentive is not there. And also I think the newborn screening alone just, to me, it's very, very hard to achieve to the meaningful longitude study. And another thing I want to make comments is because NBS TRN come across like research, this is a kind of sometimes kind of become a little bit difficult for the program direct connection. So I was hoping something between that have a surveilling flavor in it. I was thinking like a newborn screening, because CDC pretty much doing like testing part, follow up most of the new step part. So it's kind of a little bit consortium the way, and really emphasize the surveilling. And also, I think we talk about the policy important. It's really come to the cross is the program evaluation. So I think then, of course, during the process, we will address a lot of research questions. I think maybe we can think about this realm program evaluation, so become the obligation, become it's a part we needed to do. Thank you.
Thank you. Melissa Parisi, did you want to say anything? Maybe not. Jed Miller?
I apologize. That was inadvertently still up from before. Thank you.
Okay, thank you. Maybe Melissa's was also. All right.
Yeah,
well,
same for me. I'm sorry about that.
Oh, no problem. Thank you. All right. Thanks again to everyone. And this was, a really great session. I appreciate all your input, and we'll, take all the comments under consideration as we think about, how we move this forward and what steps we can take to make it happen. Is there any new business? Do committee members have any announcements or new business at this time? All right, not hearing any or seeing any hands raised. Then I want to remind everyone that our next meeting will take place May 13th and 14th, 2021. And the February meeting of the Advisory Committee on Heritable Disorders in Newborns and Children is now adjourned.